Here we are again. Good to be back. Good to be in the hot seat, the host seat. Another Finding Peaks episode here. So today we're bringing forward, because the viewers, the people on the other side of this camera have been interested in, I know this world talks about COVID all the time and for very good reasons, but the viewers have been interested in what does that look like, I think, within addiction treatment culture, and also, too, what are the sort of dynamics, the features of it that we're starting to see maybe starting to take place, you know, within current programming, and to just talk about that a little bit. So excuse me, viewers, for having my phone out here, but we've got some data on this, and sort of what took place during addiction treatment as the height of COVID was taking place was there was a lot of movement to telehealth practices to create that distance and so forth in addiction treatment culture, but the data is in, and so what it kind of looked like within addiction treatment culture was 85% of all treatment was delivered face-to-face and telehealth, sort of a back and forth. 82% of all treatment was delivered face-to-face, still an inpatient program, and 69% of all treatment was delivered telehealth only during the pandemic, or certainly during the height of all of the lockdowns and so forth. What's interesting about the data is that 91% satisfaction with face-to-face and telehealth, 85% satisfaction with face-to-face only, and 76% satisfaction with telehealth only, which lets us know that in some way telehealth wasn't totally satisfying to our patient demographic. And so I'll just read a few quotes here from that survey. I very much need to be at in-person groups. These telehealth stuff has been very hard for me, especially when people are in the group and they never reveal their faces. This other comment is very straightforward: Zoom sucks. It really put a damper on my recovery. I didn't like the Zoom meetings. It wasn't like in-person meetings. Going from regular person meetings where there were bonds and physical embraces with other fellow addicts to the Zoom meetings made me feel more isolated and depressed. The Zoom sessions are still challenging because we can't hear everything people say, so technology issues there. And finally, Zoom meetings are great in a pinch. However, I don't get the same benefits as I would from in-person meetings. So my takeaway from the reading of that is that, first and foremost, there's a big part of recovery journeys is about interdependence, right? Connection and so forth. And where am I going with this? So having some interdependence and connecting features, it seems like we got away from that in telehealth strategies. And I know at Peaks we had a ton of challenges because we didn't have internet and all these sort of features about it. But, you know, kind of going back and reviewing namely what it was like for us, Jason, at that time. What was your experience about being an inpatient program at that time, and what we saw from the patient demographic, because we couldn't bring in outside services, we couldn't bring them off campus and all these sort of features, and I definitely want to recognize that I think it caused something.
It definitely caused something. It's interesting listening to you talk, because when I go back in that period of time, first of all, one of my first reactions was I felt a lot of frustration, frankly, with some of the national organizing bodies in our field, that we got no direction for how to proceed in a pandemic. And like I remember even like 5 or 6 years ago when we were writing our policies around for the Joint Commission, you know, I think we probably had a pandemic response page or something, and it did no good. Like we had a completely,
it's like a paragraph,
yeah,
not a page. Yeah.
And I remember there was a day where I think one of our clients, like this is way early on, like just when the pandemic was beginning, where we had a client with a fever, and like we sent all clinicians home, and we're like, we're gonna go all online. It was just a very reactive period, I think. The world was afraid. We didn't know how to adjust and cope to it, and then we had no direction, I think, from anybody, frankly, and so we were making it up on the fly. And I think it took us right around, 15 minutes to figure out that going all Zoom was going to be a huge mistake. Trying to manage a room, none of us were trained on how to do teletherapy either, and there wasn't a class in at least my master's program about how to do telehealth. Of course, when I did my master's program,
No
it wasn't it was carrier pigeons, but we couldn't even figure that out. But I do think, overall, what we ended up doing at Peaks is we created a couple different clinical teams actually that would come in for 7 days and then be off for 7 days. And I'm not sure that was the best plan either. However, from that model, we started to figure a thing out where the clients were on our campus, and we got to put on these 7-day kind of intensives. As each team came in, we did kind of an intensive week where 7 days in a row they had the same clinicians, and then those clinicians were off and the next crew came on. And so from that, actually, we birthed some remnants of that as our current curriculum, honestly, that we found that really taking a topic, instead of having one group a week for the course of their stay, but how about taking a week and actually having a topic for a week, created a level of depth to the topic and a continuity and a real cohesion amongst the clients so that they had one topic to work on. I don't know if that answered your question really, Brandon, but that was my recollection of it. It was rough, and we learned some things from it, to put it in a sentence.
And thank you for yielding that question because it was pretty open-ended and broad. Thought you did great.
There was one question, so it was really helpful.
Things were greatly frustrated during that time, but I think what's unique about this as well too, Clint, you weren't with us in that inpatient model, but you were working for an opioid treatment program known as OTP models that exist out there as a clinic, and so I think that adds some, flavor and perspective as well too to what that dynamic was like for those operations, and sort of curious in an entirely different setting in that regard, what that looked like for you guys in that going through that.
Yeah, it was much different. I mean, the outpatient world, we went essentially overnight. We went 100% telehealth. At least with the counseling component of the programming. We also had the medical component where people would come in daily for medication. And rather than, a small campus of people, we were serving across the 3 clinics around like maybe 1,200 people. So the risk of transmission and the fear and the was incredible. And we were limited. You can only bring like 10 people into a facility at a time, and that included staff members. So we had these huge lines of people around buildings. It was chaotic in a different way, and logistically was challenging for sure. But to Jason's point earlier, I was at the time in charge of quality assurance and documentation, and so basically got kind of pegged along with the other leadership members to create a telehealth program out of thin air, basically, because there was. Even though I went to school and graduated at a later date than Jason, there was still no telehealth training. It's kind of always been a fringe kind of thing that, again, overnight had to become the forefront method for communication and delivery of services. So I remember going to training after training. We would just find random trainings wherever we could, plug yourself in, try to get some insight into what the world was doing, not only from a clinical perspective, but also from a medical perspective, because those clinics have both components. So it was intense, and but it was effective, and it worked, and we were able to nail something down. And again, take different pieces of that and build better programming overall. Yeah, and I think the biggest thing that I learned from that was it actually forced a different level of communication. Now at Peaks we use Google Chat, right? Or a lot of people were using at the time. We were using a Microsoft platform, but they're the sort of chat message culture where everything became very much real time. Access to individuals within interdisciplinary teams actually improved in those moments. So I think that the cohesion within within staff became much better. Everything became real time. There was not nearly as much lag, and there was it kind of forced everybody to really talk to one another. So for that, I think that's the one thing that I took out of it that I think will just never go away, at least
You talking about that, Clint, we have 3 different campuses, right? We have our men's campus or women's, and then our administrative campus. And I hadn't thought of this, but we used to really feel very separate before COVID. Like everything felt so separate, but now it is nothing to have meetings with people in person and on video. And so though I think the clinical challenges are there, I do think our meetings and the quality of the meetings are the same virtually or in person, which I think is another interesting shift. Like to even comprehend having video meetings, it just wasn't a thing.
And I think we're all much more tech savvy now. I mean, it just kind of, you had to become tech savvy. And now, even though we're not, we do focus almost really on the in-person exchange for clinical services and medical services at the residential level. I think that we know how to utilize these technical components in order to actually accentuate rather than replace the sort of programming that we have. And I mean, you guys have 3 campuses, and at the time I was working for 3 clinics in 3 different cities. So being able to communicate to every single clinician at the same time with the most recent up-to-date information, I think that now that same sort of practice happens at Peaks, and I think it and just keeps, again, everything is all about right now. There's no lag, and I think that the quality of care for the client has greatly improved and benefited because of it.
Yeah, absolutely. I mean, if for any addiction treatment center that was paying attention during that time, there was incredible opportunities to learn more and grow as an institution, and I think 100% it forced that growth almost immediately. I remember just sitting myself at my dinner table at my house at nighttime trying to figure out how to use JMF and IT software and this sort of thing to connect iPads to put into patient rooms and that sort of thing and keep people separated and distanced. And so in that regard, it was real-time learning how to do things with limited resources to be able to pull it off. And so sort of invigorating in hindsight, and certainly propelled our company forward. I'm sure many addiction treatment cultures forward at that point as well too. But also thinking about, so logistically, the industry should have gotten better in a variety of different ways. But there is, at the same time with all the social distancing, the public health orders that limited people and travel and all that sort of stuff, created a lot of isolation for individuals. And overworking, particularly for our company and supporting our admissions department over the past 7 weeks or so, I hear it a lot on the phones that I was a sort of normal drinker. I felt like prior to the pandemic, I got isolated, and then just me sitting in my home with that bottle, it became my next friend, my best friend, in fact, in that regard. And so in many ways, that lack of interdependence and that isolation caused significant issues for individuals who otherwise may have just been on normie style journeys in that regard. But mental health acuity seemingly went up, and certainly addiction, I think, went up as a natural result of that, especially alcoholism. So I've heard it on the phone, certainly brought people into the center, who've had that story. And then, now in your guys' experiences and hearing, in group settings and individual settings, what does that kind of look like that we can share with the viewers of what this has caused through that clinical lens?
Yeah, there developed a new demographic of client that I hadn't seen before, and they were particularly service workers, right, that got laid off, and then got unemployment checks that were. I had a lot of people come to me and say, I made more money on unemployment than I had ever made in my life, and I was sitting at home alone. And then there's an app that I don't really care to advertise where they could order liquor delivered to their house every day. And it created a perfect storm of really young service industry alcoholics. And we have started to see them come to Peaks where, to your point, maybe they push some boundaries with how much they drink, but being at home and being isolated and then having access to an entire liquor store through their phone that would be delivered and having more money than they've ever had with no really other way to spend it, it created this demographic of people that were really isolated and alone. And not to mention, the overdoses are through the roof last year, right? I think that data is in and clear. And suicides are up dramatically as well. That isolation piece is certainly a hidden component of this pandemic that we are still feeling the reverberations of that, I think.
Absolutely. And I think it goes to that idea, that the opposite of addiction is connection.
Correct.
Yeah. So this lack of connection triggered or pushed over the edge people that were maybe already teetering or feeling slightly disconnected, or maybe, I don't know, if you're like me, work is a huge connection. That's all I do, because you know that very well. So, you guys are my best friends.
Yeah. This is your social time right now.
Social hour right here.
True.
Yeah, this is the best 15 minutes of my week. So, but I think that losing it shows, I think, as a society, how important it is for us to stay connected to one another. And when we don't feel connected, we have this void that sort of forms, and we're going to fill that void however we can. And at the time, when you can't leave your house, I mean, what else are you going to do? Netflix will only take you so far. So.
When I think it is an interesting point, because on the flip side of that, my experience during the pandemic too is that, like, I saw my family and then I saw my work family, and that is it. I didn't see my extended family for months and months. I didn't see my friends, we all got very isolated. And to your point, like, fortunately, we worked in an industry that needed to keep showing up and being on campus, and what a grace that was, honestly, because, when I've had these clients come in and are like, I was at home getting a $600 a week check, right. Part of me is like, yeah, that had been me. I don't know how I would have coped with that. That's crazy.
And even being, watching people, having our whole clinical staff work from home, right? Like, starting off, people they look okay in the beginning, because you're doing video calls all day long. I always made a real effort to always do face-to-face calls, like make sure, like, hey, turn your camera on, I want to see you. I just think it's important for us to be able to connect and see one another. But there is a sort of steady grade of a decline of mental health in general. Because I think even that virtual connection, it's better than nothing, but it's no replacement. And I think that kind of speaks to the data that you mentioned at the very top of this, that that need for actual interaction and connection, even within a physical place, even if you're not touching, there's just some sort of like energetic mumbo jumbo that's happening that actually helps us stay healthy and stay, I don't know, human.
Yeah.
Really. So.
Yeah. Well, I have never read in any textbook in our field where an entire population is going through a shared trauma.
Right.
Clinicians, clients, like, some of those walls of, like, it started to come down, that we were all kind of in it.
Absolutely.
And we were all kind of, this wasn't like I'm providing this counseling. It's like, well, we're all kind of trying to survive.
Right.
And I remember too, like, if clients wanted to leave during that time, I'm like, can I explain to you what the outside world is like? You have more social connection in here. You have more freedom in here. You have a basketball hoop. You have all these things you can do in here. You go home, you don't have any of this. Good for retention, Brandon. But.
Yeah, right. Yeah. So, I think this is great, because it ties into the initial data that I was talking as well to here, that fallout and that negativity as an experience. It wasn't all negative, but certainly individuals experienced telehealth in a positive aspect.
Sure, absolutely.
But what they lost was that connecting piece of it. What inpatient programs lost at the same time was the ability to bring outside sources and connecting, pieces into treatment in that regard. And as well too, as the pandemic continues to thrive in a variety of ways with the Delta variant, Delta Plus, the Lambda variants, and all these sort of things, what is happening that I want to be clear with the world about in front of us is that addiction treatment centers aren't armed with public health orders or any of this sort of piece at this time. And so the general propensity for somebody who comes in and tests positive for COVID is that they are going to be removed from the treatment setting and not able to access care. And with that, signing off. Thanks for joining us again here at Finding Peaks. Find us on the socials, the Facebooks, the Instagrams, the podcasts. Please be sure to email us, findingpeaks@peaksrecovery.com, for more insights and questions. Again, too, this COVID piece that we're doing here today is because of the viewers. You called on us to speak to it a little bit. So we are always going to deliver answers moving forward for the questions that you have. So thanks again for joining us. Love you all. Stay safe. Until next time.